The verse today is ask and it will be given to you. Seek and you will find. Knock and the door will be open to you. For everyone who asks receives. He who finds, he who seeks finds, and to him who knocks the door will be opened. Matthew 7:7 to 8. Okay. This is a beautiful verse. Beautiful. Because the Lord is faithful. Okay. Now, the first question we have here today would be what is associated with Lynch syndrome? Lynch syndrome is a defect in MSH2. So the question describes a patient, a 30-year-old with right-sided colon cancer, no polyps, strong family history of colon cancer and endometrial cancer. This is a defect in MSH2 gene. This is a defect in DNA mismatch repair genes. So MSH2 is a DNA mismatch repair gene, and that DNA mismatch repair gene is defected in Lynch syndrome, and this causes microsatellite instability. So Lynch syndrome, the genes can be MSH2, MLH1, or MSH6, or PMS2. So basically, that will be four different genes are mentioned here for Lynch syndrome: MSH2, or MLH1, or MSH6, or PMS2. Associated cancers with Lynch syndrome will be colorectal cancer, and endometrial cancer, and ovarian cancer. Now, Lynch syndrome is autosomal dominant. There is an inactivating mutation in the corresponding tumor. Okay, Lynch syndrome is autosomal dominant. There is an inactivating mutation in the corresponding tumor suppressor gene. Deletion of remaining normal allele, second hit leads to loss of heterozygosity and malignant transformation. Right. So Lynch syndrome is autosomal dominant. There is a mutation in the tumor suppressor gene in one of the MSH2 genes. And so there's two. There's two genes. Let's say one is gone, you're still fine. You're not going to develop endometrial cancer. You're not going to get colon cancer or ovarian cancer. But when the second MSH2 gene goes down or gets hit, it's known as second hit, then that's when you get Lynch syndrome. Next. So we're going to talk about men 1, men 2, A and B, because it's like all over the exam in different ways, different forms. But it's actually not that bad. So, multiple endocrine neoplasia type 1 is a defect in men 1. You get parathyroid adenomas, you get pituitary adenomas, and you get pancreatic adenomas. That's men 1. That's the one where you get gastric issues, like gastric ulcers. And men 2A and B is a defect in RET gene, RET. And men 2A and B, do you get medullary thyroid cancer and pheochromocytoma? Well, okay. Yeah, in men 2A and B, you get medullary thyroid cancer, and you get pheochromocytoma also. And specifically in men 2A, you have parathyroid hyperplasia. How I remember this, I think of a man step onto pheochromocyte a man step on two pheochromocytic ruts. So a man, that would be talking about men one, and that's a defect in men one. Step on two pheochromocytic ruts, that to me is men two, and in both men two A and B, you have pheochromocytoma, and the mutation is in RET, R-E-T. So the mnemonic for this is a man step onto pheochromocytic rats. So men one is a defect in men one. Step onto pheochromocytic rats. That is men two A and B, which both have pheochromocytoma, and the mutation is in RET, R-E-T. And men 2A and B are autosomal dominant. I mean, so is men 1. But in men 2A and B, you have a gain of function mutation in proto-oncogene. So it's a gain of function mutation in proto-oncogene. And you have continuous stimulation of cell division, which predisposes to tumor growth. Yep. So you had to actually really know the difference between men 1, men 2A, and men 2B. Very high yield. So a question has come up. How do you tell the difference between a laxative use and diuretic use? It's on the MBMEs. Basically, in laxative, laxative use, what's happening? In laxative use, you are pooping out all of your bicarbonate. You're pooping out all your bicarbonate. So you're gonna have a metabolic acidosis in the body. You're gonna have a metabolic acidosis in the body. And you will see decreased potassium also. So in laxative abuse, you're gonna have low bicarbonate in the blood, and you're going to see a metabolic acidosis. And if you have a metabolic acidosis in the body, how is your body going to compensate? Your body is going to compensate by using your lungs. If it's like a kidney problem, your lungs will compensate. If it's a lung problem, your kidneys will compensate. Here, since you're pooping out all your bicarbonate comes from the kidneys, and now since you've lost all your bicarbonate, you're going to have a metabolic acidosis, and then your lungs are going to compensate for your metabolic acidosis by blowing off CO2. By blowing off CO2, producing a respiratory alkalosis. So, in laxative abuse, you have a metabolic acidosis compensated by a respiratory alkalosis. In laxative abuse, you have a metabolic acidosis compensated by a respiratory alkalosis. Burn that into your brain. Okay? Now, next, how to differentiate between a diuretic use and a laxative use. So, in diuretic use, what's happening? You're peeing out you're peeing out everything. So in diuretic use, you're going to have a low potassium and a low chloride with a high bicarbonate and a high pH, because hydrogen ions are lost in the urine, so you will see a metabolic alkalosis in diuretic use due to losing H plus in the urine, and the body trying to compensate for lost H plus by increasing bicarbonate, uh, and by the body trying to increase the CO2. So diuretic in diuretic use, you're gonna have increased bicarbonate, and in laxative use, you're gonna have a decreased bicarbonate. That's how you actually tell. Okay, so in diuretic use, you're going to have a low K plus, and you're gonna have a low Cl and a high bicarbonate, and you're gonna have if you have a high bicarbonate in the body, you're gonna have a high pH. And the high pH is also due to H plus being lost in the urine. So your body is going to have a metabolic alkalosis. So on labs, you will for diuretic use, you're going to see a high pH. And in laxative use, you're going to see a low pH, which would mean you're going to see so you're going to see low bicarbonate. So you're going to see if you have low bicarbonate, you're going to see an acidic pH. So you're going to have a low pH in laxative abuse. So way to remember that diuretic, it's like a water pill. So water, I would, I know it's dumb, but it helps me. If it helps you, I guess I'm not dumb. So basically, in diuretic use, diuretic is a water pill, right? I just think of the ocean, and I think, um, yeah, I think of the ocean, and the ocean is actually alkaline. If you look it up, the ocean waters actually have a pH of 8.1. So the ocean waters are actually alkaline. So I think of a laxative use, I think of the ocean, I think high pH, high bicarbonate, and I think of if I think of a high pH, I'm going to think of a metabolic alkalosis. Next, in laxative use, you poop out all your bicarbonate, so you're going to have a low. You're going to have low bicarbonate in your body, which means you have more acid. So you have a metabolic acidosis that's going to be compensated by respiratory alkalosis. So the point is, you'll never see increased bicarbonate in laxative use. Always going to be low. Bicarbonate will always be low in laxative use, and bicarbonate will always be high in diuretic use. That's it. So, thick and thin ascending limbs of Henle's loop is impermeable to water, regardless of serum vasopressin levels. So the thick and thin ascending limbs of loop of Henle. Thick and thin ascending limb of loop of Henle. Thick and thin. Thick and thin. Okay. Yeah, thick and thin ascending Limbs of Henley's loop is impermeable to water regardless of serum vasopressin levels. Next. Okay, so the thing is, next question is talking about somebody on warfarin, and PT is 18 and the INR is 1.6. The normal INR is supposed to be between 2 to 3 for warfarin, and so this patient has a low INR, which means there's not enough warfarin in her body, and but somehow the PT is 18. So normally, uh, normally if somebody has less warfarin in their body, that means their warfarin normally prevents clots, right? If somebody has less warfarin, that means that um, they have more they have more um, possibility of getting a clot because warfarin usually prevents clots. So if they have less warfarin, that means they have an increased chance to get clot. So because the blood becomes more thick and the PT would decrease. And if you have more warfarin, the blood becomes more thin and you would have increased PT. Because PT is how much time it takes for your blood to clot, right? So normal is 10 to 15. Here we have 18, so PT is increased. So it's count. It looks like opposite effect, right? Because there's less warfarin because of we know that INR is only 1.6, and the PT is 18. So we have less warfarin, which would mean your blood is supposed. If you have less warfarin, your blood is supposed to clot more, so you would have a decreased PT. But thing is, the patient is also on phenytoin. Phenytoin is a P450 cytochrome P450 inducer. It is a it is a P450 inducer, which means that P450 breaks down warfarin really fast. So if there is less warfarin in the body, that means you have more chance to clot, and your PT would decrease. So, but thing with warfarin is that there's a specific um, trait of warfarin, which is when warfarin is first started in a patient already on when phenytoin is first started on a patient already on warfarin, phenytoin displaces warfarin from albumin, increasing free warfarin in the blood, which causes PT to go up initially. And that's why we have high PT in this patient that is both on warfarin and phenytoin. After days to weeks, phenytoin induces CYP 450, warfarin levels fall, and PT goes down. Okay, so that's what it is. I know that's I find that to be a hard concept, but it is what it is. Next. Okay, next. This concept to me for friggin' ever to understand. It is the difference between psychogenic polydipsia, nephrogenic diabetes insipidus, and central DI. Central diabetes insipidus. So, what is the question? The question is talking about a woman that. Oops. It's a lady who comes in with high volume urination. It's been going on for a few months. Her sodium is 132, which is low. It should be around 140. And so the doctor starts measuring yeah, the doctor starts measuring urine osmolarity while she is on fluid restriction. So basically, here the doctor stops her from drinking any water and starts measuring the urine osmolarity. Okay, and then after about 7 hours, he gives her vasopressin, which is ADH, to test what if she has psychogenic polydipsia or central DI or nephrogenic DI, and we're going to get into it. So this patient actually has psychogenic polydipsia. Psychogenic polydipsia is when it's a psychiatric condition where you drink way too much water. You drink so much water that you will dilute your sodium, your body sodium. That's why this patient has a sodium of 132 instead of 140. So that, and then yeah. So in psychogenic polydipsia during a water restriction test, the urine osmolarity will go up. The urine osmolarity will go up because you're restricting water. You are restricting water, so you're not drinking so much water to dilute your sodium anymore, your body sodium. So body sodium will go up, and the urine osmolarity will go up because um, you're not drinking any water, so your body's ADH will start to work to conserve water. Like it's not getting external water, so your body will try to conserve its own water. So your ADH, there's nothing wrong with the patient's hypothalamus or kidneys. So that ADH will work. The hypothalamus ADH will work to bring the body water, to conserve the body water, and that's why the sodium will fix itself to around 140, and ADH will go up. And if ADH goes up, you're uh, you're only gonna pee out a little bit, like normal amounts of urine that normal people pee out, and in that normal amount of urine, um, you're going to have increased osmolarity because osmolarity is always relative to the amount of fluid that it's surrounding. So before, this lady she was drinking so much water and she was peeing out so much. So the urine osmolarity was very less when she was previously drinking a lot of water and peeing at the same time, because the amount of solutes in the urine when she was drinking so much water and peeing is small in relation to the amount of she was peeing. So now, since she's not peeing as much, she's gonna have very she's gonna have a she's gonna have very high osmolarity in relation to the amount of urine that she's urinating. So the graph will show increased urine osmolarity while being water restricted. Okay, now at the 7 hour mark, when you give ADH, there will be no change in urine osmolarity. There'll be no change. It's gonna show very little to no change, and that's how you can confirm this patient has psychogenic polydipsia. I'll show you a graph. Okay, I know this looks scary, but it's okay. Look, so hours of water deprivation, urine osmolarity. Yeah, exactly. So this is the number of hours that the patient is not getting water, and then up here you can look at our urine osmolarity, which is the number of solutes in your urine, and you can look at this primary polydipsia. That's what we're talking about here. So you can see from hour 0 to hour 8, the urine osmolarity is slowly rising. See this? The urine osmolarity is slowly rising. And when you give vasopressin, you see this? You see this response to AVP. Okay. See this red line right here? That's psychogenic polydipsia. You see how there's no change anymore? Until then, the urine osmolarity was rising, but when you give the vasopressin, there is no change. It balances out because the body's there's nothing wrong with the body's ADH. Uh, so the reason why there's no uh, change in osmolarity um, in a patient with psychogenic polydipsia. So, because in psychogenic polydipsia, the kidneys are already normal and maximally responding to ADH in the body during water restriction, the urine is already concentrated by 8 hours. So, giving ADH does not further increase urine osmolarity. Okay, so the body's ADH is working just fine in psychogenic polydipsia. They have this problem that is drinking too much water, so that's why they are hypodiluting their sodium. Okay, next. Oh yeah. So next, you want to know the difference between central DI and Ooh no. In central DI and nephrogenic DI. So, goodness. Okay. So, oopsies. So, what you have to know about central DI is that um, central DI means that there is an issue with the ADH in the hypothalamus. It's an ADH deficiency, central DI. So think of it central DI. Think of it as your brain. Your your brain controls your CNS, right? Your central nervous system. So think of it as the think of it as the ADH in the hypothalamus is not working in central DI. So what happens when you don't have ADH? When you don't have ADH, you pee out all your water. If you pee out all your water, you have hypernatremia in the blood, and you have hypoosmolarity in the urine. So low osmolarity in the urine in somebody with central DI. So the thing is, when you give ADH in somebody that has central DI, it will fix it. The problem will get fixed. That patient is going to conserve water by increasing the ADH because you just gave them ADH, and they're gonna have normal sodium levels in the blood, and they're gonna have increased urine osmolarity because um, you give when you give ADH, you're gonna the patient is only gonna pee out a little bit, like normal people, and if you only pee out a little bit, you're gonna have less water in relation, like in relation to the amount of solutes that's in your urine. So in somebody with central DI after you give them ADH, you're gonna have an increased urine osmolarity. Yeah, you're gonna have an increased urine osmolarity. So, what's gonna happen to the graph? Um, the graph. I know I'm looking at it. I'm not looking at it actually. I'm trying to think of it in my head. Hold on. So in central DI, what's happening is that um, ADH is not working because your brain, like the hypothalamus part of your brain, is not working. So you're gonna pee out all your water. You're gonna pee out all your water, and if you pee out all your water, you're going to have low sodium. You okay? You're gonna have if you pee out all your water, you're gonna have high. Yeah, you're gonna have hypernatremia, like in your blood, and you're going to have low osmolarity in your urine. So you're gonna have low osmolarity in your urine in central DI. And once you give ADH, that's going to reverse. Once you give ADH, you're going to, because central DI is the ADH deficiency. So once you give ADH, your body's going to conserve water. If your body conserves water, you're going to have normal sodium levels in your blood, and you're only going to pee out a little bit. So if you pee out a little bit, you're going to have increased urine osmolarity once you get ADH. So you're gonna have low urine osmolarity before ADH, before giving ADH in central DI, but once you get ADH, your urine osmolarity will skyrocket. Let's see which one that would be. We're talking about central DI. This one. So this green line right here, you see how urine osmolarity was very low before giving ADH, and then once you give ADH, the urine osmolarity skyrockets like this. Now, nephrogenic DI, that is a flat line, because in nephrogenic DI, the problem with that one is that the kidneys are not the kidney receptors to ADH are not working. So it doesn't matter if you give ADH, the kidneys cannot sense the ADH. Therefore, the kidneys cannot work to conserve water because the ADH receptors in the kidneys are not working. So you still pee out all your pee out all your water because of lack of response of ADH from the kidneys, and you pee out all your water. If you pee out all your water, you're gonna have hypernatremia in the blood, and you're gonna have low urine osmolarity because there's so much water, so there'll be less solutes in relation to how much water you're peeing out. And once you give ADH, there's no change because the problem is not with the brain producing ADH. The problem is with the kidneys understanding that kidneys sensing and understanding. Oh, I need to use this ADH to hold water back in the body because my person is being dehydrated, but the kidneys are resistant. So it's nephrogenic DI is like having no response. It's like having no ADH in the body. Same thing. Nephrogenic DI, think of no ADH. Like, no matter what. No ADH, no matter what. So, yeah. So, that one. So, see how it's a flat line even after you give the ADH? See that? Yeah. Okay, so that's that. Okay, I know I said that in like 15 minutes, but the thing is, it took me like 3 years to understand that. I'm not even kidding. So, yeah. Okay, fine, maybe 2. Next, we have VHL gene. It's a tumor suppressor gene. It's on chromosome 3p. This is von Hippel-Lindau syndrome. You see hemangioblastomas. You see clear renal cell carcinoma. You see pheochromocytoma. It is autosomal dominant. There's an inactivating mutation in the corresponding tumor suppressor gene. Deletion of remaining normal gene second hit leads to loss of heterozygosity and malignant transformation. Hemangioblastoma is a rare benign non-cancerous tumor that grows in the blood vessels of the brain, spinal cord, retina. That's seen in von Hippel-Lindau syndrome. Okay, so next we have G6PD. G6PD deficiency is an X-linked recessive disorder that causes hemolytic anemia, jaundice, dark urine, low haptoglobin after exposure to primaquine. we see erythrocyte lysis, increased bilirubin, increased lactate dehydrogenase, decreased haptoglobin. You see reticulocytosis as compensation. Loss of G6PD function causes loss of NADPH in erythrocytes, and this causes loss of reduced glutathione, and this causes erythrocytes to not be able to handle increased oxidative stress when exposed to fava beans, dapsone, primaquine, sulfonamide, and isoniazid. Patient gets hemolysis. So in G6 PD deficiency, you will see peripheral blue inclusions, which are broken down hemoglobins in the RBCs. So you have to know that G6PD deficiency will have jaundice, dark urine, low haptoglobin, increased bilirubin, especially increased direct bilirubin. Normal um, normal direct bilirubin would be 0 to 0.3, but in the question it shows zero point 0.5, and the total bilirubin will also be increased. Normal bilirubin is normal total bilirubin is zero point 0.2 to 1.2, and then in G6PD you're gonna have increased total bilirubin, and the reason you have increased direct bilirubin is because bilirubin is produced faster than the liver can conjugate it, or the liver's conjugation process is impaired. So unconjugated bilirubin, which is indirect bilirubin, builds up in the blood. Okay, freaking conjugated and unconjugated bilirubin. Okay, there's three things you have to know about bilirubin. The total bilirubin is zero point 0.2 to 1.2. Unconjugated is also known as indirect bilirubin, as if medicine wasn't already hard enough. You have multiple names for the same thing. So unconjugated bilirubin also is also known as indirect bilirubin, and that's 0.2 to 0.8. And conjugated bilirubin is also known as direct bilirubin. How nice. And that is 0 to 0.3. These are normal levels. In somebody with G6PD deficiency, you're going to have increased total bilirubin, and you're going to have increased um, direct bilirubin and increased indirect bilirubin. You're going to see you're going to see unconjugated hyperbilirubinemia, um, which is indirect bilirubin, because the liver the liver's conjugation process is busted, so bilirubin will end up, like the indirect bilirubin will end up in the blood because it can't be converted to conjugated bilirubin in the liver. So the indirect bilirubin will build up in the blood, and that's why you get jaundice. And G6PD is X-linked. It presents as a boy with hemolysis leading to jaundice after you give a sulfa drug, or dapsone, or primaquine, and you see degmocytes, which are bite cells with blue little bodies inside of them, known as Heinz bodies. Very high yield for the exam. People mess it up all the time because it's confusing and annoying, but you still gotta know it. And G6PD, you're gonna have low haptoglobin. That's because red blood cells break apart in the blood, releasing hemoglobin, and haptoglobin gets used up, binding that hemoglobin, so its level goes down. So in G6PD, there's hemolysis. And when there's hemolysis, hemoglobin leaks out into the blood, and then haptoglobin is like, oh no, I have to go and save all these little hemoglobins, and so haptoglobin goes out because he thinks he can save everything, and binds the hemoglobin. And if you bind the hemoglobin, like whenever you bind something up, it gets used up. So haptoglobin gets used up, and that's why you have low levels of haptoglobin in G6PD. Okay, next, membranous nephropathy, very high yield, but it's not as annoying as these genetics. You know, like the annoying other things. Thank God, step on his pass fail. Okay, membranous nephropathy, most common cause of nephrotic syndrome. Okay, in white people. So membranous nephropathy is the most common cause of um, nephrotic syndrome in white people. It is caused by antibodies against the phospholipase A2 receptor. You see a spike in dome appearance on electron microscopy. Immunofluorescence shows a diffuse granular pattern of IgG